Okay. Okay, let's talk about the management of first presentation and what may be the prognosis of labor, what may be the outcome during labor. When the chin is in the anterior position, there is less difficult of the chin. There is less difficult of this chin when the head is well extended, and with effective contractions, the chin will rotate forward and the face will be born with the chin in the anterior position. We shall see that other part when the chin lies in the posterior position, what happens. So during the management is so easy. I've talked about it, that if it is diagnosed late in pregnancy, or the mother should be referred to hospital. If it is seen as secondary in second stage of labor, it is managed first of all by extension and then flexion. And if diagnosed during labor, carry out vaginal examination to carry out the position of the chin. And in case if it is mental posterior, refer to hospital. We shall see why it is mental posterior should be referred to hospital. And the nursing care should be the same like any other pregnant mother, using a pantograph, watch for descent of the presenting part, monitor the fetal heart, and if there may be prolonged labor, of course, carry out vaginal examination after rupture of membranes to rule out cord prolapse, and take care whenever you make a vaginal examination, take care not to injure the baby's eyes. The midwife must make close observation to make sure that the chin is in the lowest point and that the rotation and descent are taking place. If the head remains high in spite of good uterine contractions, possible chances that it is mental posterior. This mother should be referred for cesarean section. If it is second stage, carry out an episiotomy to prevent lacerations. And when the face appears at the vulva, the first thing we do is extension is maintained by holding back the symphysis to allow the chin to escape under the symphysis pubis. You are going to see it in the video, before the occiput is allowed to sweep the perineum. So in brief, like if the face presents like this, the first thing is we shall aid extension. Instead, we shall aid extension of the head such that the chin escapes first. And after the chin escaping, then we shall also aid flexion in order for the head to be born. So we shall see it as we do it. In this case, the submental vertical diameter 11 centimeters distance the vaginal orifice instead of the mental vertical diameter. So this happened when the mentum is mental anterior. But there are some times when you have the chances of mental being in the posterior aspect of the pelvis. Here we go ahead, the mechanism is longitudinal, attitude is full extension, presentation is face, denominator is mentum, position is right mental posterior. Again, internal rotation of the head will take place and the chin will become the leading part. The chin will meet the resistance of the pelvic floor muscles and it will rotate an eighth of a circle to come and lie under the symphysis pubis. So I'm going to explain this better with the video. Please switch on to the video and see. But in mental posterior position, in most cases, there is obstruction, and this mother will end up for cesarean section. Please watch the next video.